doctor. Okay, are you comfortable if I sit here? Can you see me okay?
Yes.
Okay.
Can you see him okay?
Yeah, I can see him okay.
Okay. So I'm a medical oncologist, a chemotherapy doctor who specializes in taking care of people with brain tumors, and I've been here doing that for over 25 years now.
Well, you must have a degree of expertise.
I've seen this before, yeah. So the disease you have or the tumor you have, and I know they've told you a bunch of things, but I'm just going to start fresh for a moment, is called a primary central nervous system lymphoma. So lymphoma is a much more common cancer that you've heard about, famous people getting Hodgkin's lymphoma and non-Hodgkin's lymphoma. It usually occurs in the body. 97% of the time it occurs in the body. Only about 3% of the time does it occur in the brain, and it's only in the brain, and we think that's where yours is. That's why we call it primary, started, central nervous system, that's the brain and spine. So it started in the brain and spine, as opposed to lymphomas, which are a cancer of the blood cells and lymph nodes that usually occur here. In the brain, it's the same lymphoma, has a couple differences, but for all intents and purposes, it's sort of the same, but we wind up treating it a little differently. This lymphoma happens for a couple reasons. People who are immunocompromised, maybe they've had a kidney transplant or a heart transplant, or they have infections like AIDS and other things, there's an increased risk. But we also see an increased risk as we age in otherwise healthy people. So many people have no real risk factors. They're not immunocompromised. They're just aging. And I see this in 20-year-olds and 40-year-olds and 50. So it's not just in the older population.
That's just the kind of cancer my wife had.
She had lymphoma,
No, she had a lung
a lung cancer. So
but no family history.
yeah,
No,
yeah. Yep.
no smoking.
Okay.
No obvious risk factor.
And as far as I know, you don't have an obvious risk factor for this. So what do we know about this cancer? This lymphomas of the brain, although they show up in an area, we can point to it and say, there's the tumor. We know that those lymphocytes, those blood-borne cells, can actually spread throughout the brain and the spinal cord and the spinal fluid, and actually even into the eyes, because the nerve from the brain goes into the back of our eyes. And so we consider this kind of a whole brain disease, even though we just see, one tumor on the scan. Without treatment, this tumor grows and generally will take somebody's life in a matter of months, and usually not many months. It tends to be a fairly aggressive tumor, and the brain just can't put up with cancer growing in it very much. It starts shutting down when that happens. Brain controls everything that happens in our body. The lymphomas can be kept at bay a little bit with the steroid medicine. So you're on a medicine called Decadron or dexamethasone. That helps with the swelling around these tumors. So you may have felt better since they started that. For lymphomas, unlike other cancers, that steroid medicine also can kill lymphoma cells. Now, it doesn't tend to kill all of them, but it can kill some of them. So the tumor actually can get smaller and people can feel better just with the steroids. But with the steroids alone, that's a temporary thing on the order of a couple months before it learns to grow despite the steroids.
So the cancer's been stopped.
Well, it may or may not be. In some people, the steroids don't stop the cancer. But I'm just saying, you might feel better, your scan might look better, and we would blame that on the steroids. It's a good thing, but it's not a permanent solution. Lymphomas of the body are one of our more treatable tumors and are a curable tumor. Not in everybody, but in a percentage of people. Lymphomas of the brain are one of our more treatable brain tumors, and they can be curable in a percentage of patients. Somewhere between a quarter and a third, we think, maybe a little higher. Most of those patients are younger. We know as we age, the chance of curing this tumor goes down. So I don't have a clear percentage, but I can tell you that in some people, even your age, these tumors can be made to go away and stay away, possibly for years, but that's not nearly everybody, and it takes a big whack to do that. it's an aggressive treatment. And I know that may or may not be what you want, but I just want to give you the lay of the land. In general, the most aggressive treatment for this, which is the best way we think to treat it, relies on a drug called methotrexate, given in very, very high doses in the vein. It's done in the hospital because if we didn't rescue your body from those high doses with an antidote, you would die from that. Your bone marrow and blood cells would go away, and you'd have sores in your mouth, and your liver would fail. So it's a finely choreographed dance of giving you these super large drug doses to kill tumor, and then trying to rescue the body. Usually it goes well, sometimes it doesn't. And we see a variety of side effects from that methotrexate, almost always to some degree, like tiredness, lower blood counts, sores in the mouth, maybe some liver changes. More rarely we can see the kidney get affected or even stop working. And there have been people who have had their kidneys stop working. We do everything, again, very aggressively to prevent that. And knock on wood, it doesn't happen very often.
I bet polycystic kidneys, don't they?
And you're 85 years old, which although your kidney function looks good by the lab, but that's what I worry about most. There are other drugs that we combine with that, one of which is an IV drug called Rituxan or rituximab. It's what's called a monoclonal antibody. So a totally different way of treating it, but it targets the B lymphoma cells and can kill them. And that's a medicine, tends to be better tolerated. You can get reactions the first time or two you get it, but overall people do reasonably well with that. We can talk more about it. That's probably an important part of the treatment for this. So in the most aggressive setting, and I have a handful of patients getting treated right now, high doses of methotrexate every 2 weeks to 4 weeks in the hospital, Rituxan every week for a month or two, and maybe even another drug, a pill form of chemo called temozolomide. So I tell people it's a big investment to try to get better from these tumors. If you're going to try to go all out and stop them, it's a big investment. We know that older people do worse than younger, but it's a continuum. And it's much more important your physiologic age, how healthy you are, rather than your chronologic age, how many birthdays you've had. I have 50-year-olds who are sicker than any 85-year-old I've ever treated, and I have 85-year-olds who are, who could kick my butt at the playground and, and in good shape. And so that's probably more important.
Mm-hmm.
I would say that one of the things I use to try to help patients decide whether to embark on this is, how were they before the tumor? For people who were really in good shape before the tumor and it hasn't been too long, I think the chance of kind of getting back towards that is higher than if people were very sick or they've been sick for months and months and months, and then the chance of kind of getting back goes down quite a bit. I think in my way of thinking, I would say there is probably a small chance of curing this tumor. There is a much larger chance of treating it and getting a nice response that could last for months or even years. And then there's a chance that what we do won't work and you will get sicker despite what we do.
What are the odds that it's an improvement that could last for years?
Yeah, I think, are we in the realm of 25%, somewhere around there? And I'm guesstimating a little bit, but that's the ballpark, I think. Maybe as high as 50% of some improvement for at least a few months with the treatment. It depends a lot on what side effects the treatments cause to knock you down as opposed to lymphoma. I think in somebody in your situation, I think there are 3 options, and I'm not going to present them in any particular order of preference. One is to do nothing. One is to say either, that sounds great, but I don't want to go through all that. I don't want to take the chance of having side effects from what you do or feel bad. I understand this cancer will take my life. Take care of me as best you can from a symptom standpoint, and let me be as good as I can be for as long as I can be. That is a reasonable option in someone your age with this tumor.
It's reasonable.
Well, let me go through the other options and then come back. Can I do that?
Okay.
again, if you were 40, I would try to twist your arm higher, because I think the chance of a better outcome goes up in somebody whose kidneys are in 40 and whose liver is 40. So one option is not treating this. I would expect that the tumor would take your life within months, not many months or years. That would be my guess, although the steroids might allow a little bit better outcome. And that's the best guesstimate I can give you. I think on the other end is the real aggressive treatment that has a much higher chance of side effects, possibly even severe side effects, but a higher chance of this going away and staying away for a longer period of time. And that involves the methotrexate with the other drugs.
How long could that period of time be?
Well, I think, the treatment time we estimate is like 6 months of treatment, on and off. It's an aggressive. But again, I have people, I'm trying to give a fair comparison of folks I'm treating now. I can think of about a 50-year-old, mid-60s, maybe an early 70. They've all had this for a couple years. In 2 of them, it's come back. We've treated it again. It's gone away. So they're not cured, but they've had several years. One, the guy who I think is in his late 60s, it went away for 5 years and came back, and now we've treated him again, and we're hoping for the best. And so, 85 bothers me a little bit, not because you've not been healthy or I have anything against 85-year-olds. It's just your kidneys are 85 and your liver is 85, and it just doesn't have the reserve that somebody of a younger age would have. And no value judgment.
I don't have that.
Well, nobody who's 85 does, but you're on the top of the 85 list, but still your kidneys have worked hard for 85 years. And so we think they have less mileage left to go than someone who's 40, just practically speaking.
Yeah, even a healthy 85, how many years could you have?
Well, if you're a woman and you reach 85, you're going to be expected to live at least another 10 years. You've made it to a point where you're self-selecting out. Men survive less than women, but again, I don't know off the top of my head. My guess is if you were healthy, a healthy 85, the life tables and things would predict you'd make it to 90 with a great certainty, because you've proven you're pretty healthy by getting to 85 and be healthy. But you're not without, you're not, quote, normal now. You have this tumor that has to be addressed. I do think there's an aggressive and then there's that less aggressive. There's probably a middle of the road option. If you want to dabble a little bit and see, are we lucky enough to get a quick response and a nice response that maybe gets you feeling a little better so that we could then maybe get a little more aggressive. I've treated patients a variety of ways. There are the steroids, that Rituxan medicine by itself, again, tends to be well tolerated. You need an IV that will stay in a port. There's some, it's treatment, and there's a chance of side effects, but really it's pretty well tolerated, and it has a chance to have a nice response to see maybe the tumor would shrink, you'd feel better, and we could do a little bit more. There's this pill form of therapy, the Temodar, that we could even add in if we saw you were doing okay. There are some other pills that have activity against CNS lymphoma that we could think about. All of them have this potential for side effects. Many of them most people don't get lots of severe side effects, but anything's possible. So I don't want to create a rosy picture where you won't have any side effects and you'll feel great. I can give probabilities, but it could be that you get the sickest of anyone I've ever seen, even with these easy treatments, or it could be you fly through them and don't have one. To me, I think the decision in part rests on where your mind is, and most people who I've talked to and helped take care of who are your age have thought about lots of things. They've thought about, what to do if they were going to get sick, what they might want, especially if you've had a spouse go through a serious illness, you're forced to confront those decisions. And I have older patients who say, I've lived a good life, I'm just not interested in going through anymore, for a chance of helping. If you can guarantee, yeah, but And I have other patients who say, you know, I'm 85, I've seen a lot, I've done a lot, I know what I want, I don't want, and I want to be really careful as I go through this to always have somebody looking out for me saying, nope, I'm too sick, he would never want that, you know, and change horses in midstream. But, you know, if I could live another year or 6 months or 2 years, hey, that would be great if I could see my grandchild do this or my spouse do this or whatever it might be. So I usually find that people like you have kind of made up their mind to a certain degree about what sorts of things they're willing to do in a kind of a serious illness situation.
I have.
And what are your thoughts?
That I don't want to go through that chemo
Okay.
for such a indefinite outcome.
Okay. And when you say that chemo, I know you mean the aggressive methotrexate one. Does that also include kind of the less aggressive ones, the ones that might be better tolerated?
It seems to me that if one's going to make a decision to go through chemo, one ought to go all the way,
Mm-hmm.
because it's still a disruption in one's life.
I think I understand, and I don't necessarily disagree with you. I think that's a very appropriate way to think about it. You know, if you're gonna go for the win, go for the win. You know, don't play to tie, so to
Right.
speak.
Mm-hmm. What do you think, Jeff?
I understand where you're coming from, and he's in rough shape right now. And I mean, just seeing my mom go through it, she was healthy, and it took everything she had. And
Sure.
I guess my concern is that the shape he's in currently, is that pretty? I mean, would he even make it through chemo treatments like that? That's
Yeah,
really
I
it.
mean, that's, you know, again, it's basically you're either all in or you're not, and you try it, and you go in eyes wide open and understand that, you know, there are good features and bad features,
Yeah.
and you have to see how they play out, and the fact that you're not, you know, light on your feet and feeling great and function, you know, that kind of is in the bad column, and
Yeah.
says there's more likelihood of seeing side effects.
So it improved it. So if it improves it somewhat, would it is it likely that it could improve all the way to when I was functional?
Yeah, I think I would say there's a chance of that. That's probably a low chance. I would say it's a more likely chance that you would, you know, our sort of best, not our best, but our near best would be a significant improvement, but maybe not quite back to where you were. And I don't know that I can give you a percent chance, but it's sure not 100% or even 50%. It's probably less than that.
So I still wouldn't be able to get up and stand and walk, probably.
Well, I would say, I mean, to me, I would think if we were successful, you would, and that if that wasn't happening, we would stop therapy because we weren't seeing that kind of an effect. So that's the only other thing I'll say, and I am not trying to twist your arm. I just want to make sure you have
I know
the
you're not.
information.
I know you're not.
Sort of unlike the Army, once you get into this, you can get out. So, you know, if you get a cycle or two of chemo and it's miserable and you're not better, you can say, oh, great, we tried it, but no more. So I never tell people, although I say, you know, it's 6 months of treatment, you're signing up for, you know, for a day-by-day lease, so to speak, where we want to see how you do each day. At each treatment time, we evaluate whether it looks like it makes sense to continue. But again, I think if you were 70 or less, I would be twisting your arm right now. I think the absolute right thing to do is do treatment. When I have people over 80, I just understand that there's more of a chance of side effects and a bad outcome. If you said, I want to do this, I'd be all in favor of it, as long as we understood, you know, the risk. But I never want to treat somebody who doesn't really want treatment. I always think we need to be in tune that we're willing to put up with stuff because that's where we want to go. And again, I do think, and I don't mean to be blunt, but that's why I'm here. At 85, we don't expect you to live to be 105. Most 85-year-old men don't live that long. Most 60-year-old men live to be 80. That life expectancy. A 40-year-old, yeah. So it's always different because we know we have forces working against us called aging that are out of our control. That even if you are very healthy, most men don't live past 90 and 95. Women more so, but not men. And there are exceptions to that, of
Sure.
course. But just if we play the law of averages, we don't have as much to gain. But I never let that stop me if somebody says, I want to go for it and try.
No. What was I going to say? One has to weigh the possibility of living a few more months, maybe free of pain, than closing out one's life in pain.
I couldn't agree more. Although with brain tumors, pain usually is not a big problem. Most of the time people just function less well, wind up spending more time in bed, more time sleeping. That gets progressive. That would be the typical downhill course for people with brain tumors. They can have headaches, they can have seizures, they can have weakness, all sorts of things, but mostly it's sort of just getting less and less awake and less active.
That's not an attractive way to look at remainder of life.
I understand.
Life.
And what I would say is if you are choosing not to have therapy, you can stay on the steroids to try to get a benefit from that. For now, I would ask them to get hospice involved because they can provide help at home, or if you have to go to a rehab center or wherever you need to be cared for, hospice can help, and they can help more as you have more needs. They can help family with counseling and with medicines and things. So it's a great resource to have.
Is that somewhat better than a nursing home?
Well, it's different. Hospice won't come to your home and sit with you 24 hours a day. I think a nursing home versus home, the decision is, can you be taken care of at home with the nursing and medical care you need? For many people who are weakened and disabled, the answer is no. There's not enough family, people have to work, they don't have skills to help you, so that you wind up needing to go to a nursing facility. And in a nursing facility, oftentimes hospice doesn't really have to get involved right away because they won't do much, but sometimes it helps for the family, to know they're there. And if you were to need more of an inpatient facility, hospice has an inpatient facility, so it's not a big busy hospital, but there are doctors and nurses, and they can do all the things we do for symptoms. They're just not going to try to treat you.
That sounds like an attractive option.
Yeah, and generally you only do that when people are really sick, so they wouldn't. You're too healthy to go into the hospice home right now. But I think the team with physical therapy and everything would have to decide, are you safe to be at home with all the things we can do at home or not? And that would be the distinction between going to sort of a nursing facility versus going home. They can have hospice meet you, and are you in Forsyth County?
I'm in Guilford, but he's in Forsyth. Yeah.
So they can have them meet you and meet your family and either choose to be involved or say, when you need us, call us, here's the number. So I think that's always helpful. But the decision on where to go is sort of you and the medical team over what help you need to get through each day.
My question is, so Dr. Lambert, I think, was talking
he's one of
yes.
my partners who came by last night.
Yep, he came by, and then Dr. Hernandez came in today, and they both said, so kind of right now, where he's at right now, you also needed to check his eyes and potentially his other parts of the body.
Well, I think we only need to do that, frankly, if we're going to treat your lymphoma. If we're not, it doesn't really make a difference.
Gotcha, okay.
So I think if we're not going to try to treat your lymphoma, you don't need those things.
Okay.
Yeah.
Got it. Because that would, that could, the information we get from that could make the potentially worse if it's gone to other areas.
It won't. I don't think it will help us to do anything to make you feel better.
Okay,
So there's no need to get that information.
gotcha.
I want to make sure I leave. Oops. I'm gonna leave you one of my cards right here. Let me give you.
Okay,
Whoops.
gotcha. Yeah, those are tricky.
Yeah. And I won't be in the hospital this weekend, but I'll be back next week. We're all trying to balance being in the hospital and at home with the viral pandemic and
Yep.
getting work done. But I'll be in and out of the hospital, next week. They can keep me updated. I'm happy to help in any way. What I'm hearing right now is that we're not going to pursue treatment, so we're not going to necessarily pursue the other tests. I'll communicate that to the team. If you change your mind, you can change your mind at any time. You guys talk with your other son, and if that changes, they can get word, and we can kind of restart the process. There's no door that closes that can't be reopened.
Gotcha. Well,
So that offers a little time.
Yeah, I again, take
Yeah.
the time you need to talk with your family, and if things change, they can get me back, back in touch, and we can kind of move things along.
yeah.
Okay.
That's good.
So I just wanted you guys to have a fair understanding of sort of the landscape. And Dr. Lambert doesn't really treat brain lymphomas, but I do.
Yeah, I hear you're the man.
Yeah, so
Okay.
it made sense for this discussion to wait for today.
Sure.
When I could get by.
I
And-
understand.
Any other questions for me?
No, can't think of anything. Can you, Jeff?
No, the success rate of him being able to say walk and do those things you said was about 25%.
Yeah, I'm going to guesstimate that.
Gotcha, sure. I know.
think it, and it really depends on whether this tumor responds nicely like it often does. And, within a month of treatment, we'll have a sense that, hey, this is melting away. Yeah, there's a better chance that you get your strength back. But, so as we gain information, we can change that.
How
that
much
guesstimate.
strength?
Yeah, again, I don't want to promise because I don't think I can back up that promise. I think there's a chance of significant improvement, but there's no guarantee of significant improvement.
You have a likely scenario.
Yeah, again, it's just a little hard for me to say, is there a 25% chance of a really significant improvement? I think that's probably fair, and maybe that's even a little conservative.
Okay.
But I don't want to overpromise because that's not fair to you or or the family.
And I think you said if he does the chemo and he has his first one, will we see, since it's so aggressive, will we see results relatively quick so he can decide, or does
We usually
it?
get a repeat scan within a month, so kind of two aggressive treatments or 1 month of the less aggressive treatment. We get a scan in a month to try to see, and we'll see people improve over days to weeks if there's going to be a nice improvement.
Okay.
Maybe slow, but we'll see it. Yeah.
Jeff is my health care agent, and it's important for him to
Yeah, so
understand.
I think hopefully now you have the information
Yeah.
you need to kind of help, with your discussions with the family and with you.
And that he's in a position to hear.
Everybody needs an advocate.
Yep.
Absolutely.
No, I'm glad he's in position to hear my feelings
Yep.
on the matter.
Yep.
too.
And you're the boss. So
Yep.
what you want is most important, not what we want.
That's
but what
right.
you want.
Yep.
And
Yeah.
that makes his job easier.
Yep.
too.
Yep, he can disagree with your decision, but he's obligated to follow it.
Yep.
And that's the beauty of being of sound mind and being able to tell us what you want. You've earned that right, and we don't want to take that away from you.
And that simplifies his job too.
Yep, it sure does.
Gives him a clear conscience.
Yep, I couldn't agree more.
I'm with you either way.
All right. It's very, very nice to meet you today.
Nice meeting you.
Sorry it's under these circumstances. Yeah, I'll wash my hands.
I appreciate it. Same here.
Uh,
Thanks.
And again, I'll talk with Dr. Hernandez's team, and if things change, just communicate to them, and we'll sort of reconvene.
Okay. Well,